We do have first speaker Tatiana Aleksandrova, who is an interventional radiologist at the McGill University Health Center. She'll be giving both presentations back-to-back for renal biopsies and their selection and optimal energy sources for small renal mass ablation. The floor is yours.
Thank you very much. Thank you very much, everybody, again, and good morning to you all. I have nothing to disclosure. And I'm really grateful to be here with the invitation of the committee. I'm amazed of what you are doing. This is beyond AI. This is when I see the robotics, it looks like the medicine of the space. When you're going to have your hospital space center miles away from you and you're going to be doing these fantastic surgeries. So thank you for having me and giving me this opportunity. Coming back to Earth, biopsies, are we doing biopsies or not? I'm going to show you a little bit of the guidelines, like always, because it's like a GPS and to know where we are and how we should get there. And if you see, there is a dot line between the diagnostic, the first presentation, and if we're doing a biopsy or not. So this could be a little bit the question. On the ESMO guidelines, you will see that they are recommending the biopsy. Do I have a pointer?
You do.
No. How? No. I won't try. You know this by heart. But they recommend the biopsies before ablation, but they don't recommend the biopsies before nephrectomy. And the question here is, do we really need a biopsy? Because we know that a solid mass is very high chances that it's going to be malignant. But on the other hand, this detection of very early small renal mass has also increased the unnecessary treated tumors like oncocytomas or AMLs. So we can say no biopsy really for doing our treatments. If it's a small lesion, you have to consider also the technical challenges. So 10 to 15% are not diagnostic. 10% could have erroneous diagnostic because of the tissue that we're taking could be very heterogeneous. Maybe it's showing an oncocytoma, but it's not showing the part of the RCC that is next to it or something like that. It's not always feasible due to the anatomic tumor. Yesterday, one of your colleagues were showing me a tumor that looked like a crescent just at the hilum of the kidney. Very difficult to do anything on percutaneous for that patient. And we should always think that a biopsy is an extra invasive procedure for the patient. So at the end, the vast majority of small cells, small renal masses are removed without a previous biopsy. There are two special populations that they are saying that they don't need a biopsy. For example, on a young or healthy patients that they don't want to change, to have the possibility of a malignant nodule, so they prefer to go to treatment directly. So they don't need a biopsy. You will have the biopsy post-op. Or the inverse, the very old and fragile patients that would prefer to have a conservative treatment. So don't put the risk, the patient on risk. And you have listening to, during this conference, imaging is going up on classification of lesions. And what you are seeing on the presentations as a virtual biopsy. So the MRI or molecular imaging with nuclear medicine or the radiomics and the artificial intelligence are going to let us know if it's a malignant or not, and then take a decision. So the clear cell likelihood score that you have there Very simple, MRI. Is the lesion enhancing? Yes, okay. So does it has a macroscopic fat? Yes, that's an AML, don't biopsy. If it has less than 25% enhancing, that's a very possible cystic mass, don't biopsy. And then you have different characteristics that is going to give you a CCLS classification that, in my mind, I don't know why you don't call it RIRADS, because it looks so similar to the BIRADS and the LIRADS and the PIRADS, where different characteristics will give me a classification on 1 and 2 being benign, 3 equivocal follow-up, 4 equivocal biopsy, and 5 definitely malignant. The only problem is that we still have some lesions that overlap. So if you see on the bottom, we could have oncocytomas and RCCs that can get confused. So those will probably need a biopsy. This is a problem of also a biopsy. Learn from the old people like me, please. At the beginning, we were doing biopsy and ablation at the same time. That's a no-no because, for example, this patient, very small nodule on the lower pole, biopsy the same day of the procedure, and what happened is that just after the biopsy, this huge hematoma that obscured completely the lesion, and it was impossible to do the ablation, so we canceled the ablation. And finally, this patient had an oncocytoma. So somehow this hematoma saved him from an ablation. So no biopsy. Now, let's go to the other side. Biopsy, yes. Because then you can say, well, if I don't biopsy and I go to surgery, then we're going to treat benign tumors. And they can be misclassified as malignant, and during the surgery, we're going to have a benign tumor. So here it is, the different guidelines, the ASCO, AUA, NCCN, EUA, considering the biopsy, yes or no. I will not go on detail to them, but most of them are saying should be performed before TA, consider when a mass is suggestive of hematologic, metastatic, or infectious inflammatory. And then you can say yes for the biopsy. It's important to have the biopsy because we know that there are tumor characteristics that are going to be prognostic characteristics. So the morphotype, if it's a sarcomatoid differentiation or a rhabdoid differentiation, if there is tumor necrosis, the grading of the tumor and the microvascular invasion will give prognostic to the tumors, and that also will define the follow-up of the patient. And this is a very beautiful article of the new role of the pathologist, because there is a complete new classification of RCC subtypes, and it depends completely on markers, not anymore on morphology. So the ELOC mutated, the TFE3, the TFEB, et cetera, and these markers, very possible, are going to give us treatment, personalized treatment definition. So molecularly defined RCC subtypes. This classification is also bringing a new category of oncocytic neoplasms. They look for the sarcomatoid differentiation for prognostic factors and also to prognose the response to target therapies, and in artificial intelligence for imaging and pathologic correlation. So if you ask me, biopsy, yes. This is one of the most important points, because AI today is still a learning child that we have to give information to that child so they can learn. On the previous session, it was written down, data, data, data. So that's what we need. We need image and pathology together. And that would be an argument in favor of biopsy. And also, on this era of the NIBs and the MABs, that there is always a new NIB and a new MAB for a treatment with multiple studies for renal cancer. We need to know the tumor markers to give the appropriate treatment. So I'm not giving you a takeaway message because we are still on biopsy yes and biopsy no. And that will be maybe a lot of decision of your multidisciplinary team, how much oncology needs for it, how much imaging, AI, or surgery. And that's about biopsy. That's fast.